Good day, ladies and gentlemen. Welcome to the third webinar of the Pre-Analytical Masterclass webinar series brought to you by the Asian and Pacific Federation for Clinical Biochemistry and Laboratory Medicine and supported by BD. First, allow me to introduce myself. My name is Nadra and I'm from BD. I will be your moderator for this webinar. Before kicking off the webinar, please allow me to review a few housekeeping rules for this session. This webinar will run for an hour. Certificate links will be emailed to you upon the successful completion of the webinar. Throughout the webinar, you may ask questions via Ask a Question chat box located at the left lower corner of your screen. Questions will be addressed at the end of the presentations, and questions that were not addressed will be compiled into an FAQ sheet that will be sent to all participants. Should you have any questions after the webinar, please do email them to pasea@bd.com. Before we start the webinar, I would like to invite Professor Tony Bedrick, the President of the APFCB, to give us an opening speech. Professor Tony, please.
Thank you very much, Nadra, and welcome everybody to the third webinar of Series 3 of these programs, these webinar programs, which are really designed to focus on procuring better quality specimens and how to minimise pre-analytical error while ensuring staff competency. We're covering in this series and in the two previous series a whole range of pre-analytical improvements on sample collection. I'd like to thank BD. BD do more than just sponsor. BD really have been a driver in allowing us to present this program, because they realise, as all laboratory workers realise, just how important the role of phlebotomists is in ensuring that the results that we're able to obtain represent the true state of the patient, and no more so than in the area of blood culture. So today's webinar focuses on blood cultures, the collection process, and the impact that collection process can have on the quality of results of blood cultures, and therefore on the impact that it can have on patient outcomes because of results that might not be as good as they should be. So with no further ado, again, I welcome everybody. I'd like to thank BD again. Of course, I'd like to thank our presenters for them allowing us to use their valuable time and expertise to try and improve pre-analytics in our region. And I'll hand back to Nadra now. Thank you.
Thank you so much, Prof. Tony. And to kick off the webinar today, I am pleased to introduce our speaker, Dr. Juliet Elvie. Dr. Juliet Elvie is a consultant clinical microbiologist based at both Wellington Southern Community Laboratories and MedLab Nelson, Marlborough, New Zealand. She completed her training in the Southwest UK in 2011. In her role as a clinical microbiologist, she was responsible for a number of clinical microbiologist laboratories across the South Island of New Zealand, as well as the Wellington region. She is a fellow of both the Royal College of Pathologists of Australia and the Royal College of Pathologists UK. She is passionate about quality and has been the chair of RCPA QAP Microbiology Advisory Committee since 2018. She is a key member of the New Zealand National Antimicrobial Testing Committee and the New Zealand Microbiology Network. Here to speak on blood culture, pre-analytics and impact on quality, please welcome Dr. Juliet Elvie.
Kia ora and welcome everybody, and thank you so much to the organisers for the invitation to talk to you today on sepsis and the critical role of blood culture in the management of patients who are critically unwell with sepsis. As the kind introduction stated, I'm a clinical microbiologist actually now based in Dunedin, a recent move, and just to point out that our laboratories has had a recent name change and are now known as the Awanui Laboratories. So the talk today is really going to focus on the role of blood cultures in the outcome of patients with sepsis, particularly focusing on blood culture best practices and how we can optimize blood culture quality to optimize patient outcomes. So as we know, sepsis is a medical emergency and is associated with a very high morbidity, and mortality is associated with sepsis. And we know that the early identification and appropriate immediate management of sepsis can definitely improve patient outcomes. The early recognition and prompt administration of antibiotic therapy are really very key management principles. In fact, most patients that come into our hospitals with sepsis will require broad spectrum antibiotics, but unfortunately a microbiological diagnosis is often only achieved in the minority. Up to 40% of patients with sepsis will have an identified organism, and that's a problem because identifying the organism does allow for better targeted treatments and optimization of the antibiotic therapy. If we can't identify the pathogen as the cause of the sepsis, then we are unable to narrow the spectrum of the antibiotic. We may, in fact, inappropriately discontinue antibiotics due to a false negative result. So therefore, collection of blood cultures really is a very crucial step in a management of patients with sepsis. And this fact is actually recognised in internationally recognised management guidelines for sepsis. And here we can see the Surviving Sepsis campaign, which has really been a very main driver of how to care, those immediate management steps for patients in hospital with sepsis. And they do state as their number 2 step in the first hour of any patient presenting to hospital is to obtain blood cultures, and ideally before administering any antibiotics. And here in New Zealand, we have our own Sepsis Trust sepsis guideline, which also clearly indicates that blood cultures are really that second step after administering oxygen. Take your blood cultures, ideally before any antibiotics are given. So blood cultures are really remain the gold standard for the detection of microorganisms in the blood and the cause of sepsis. They are really key to identify not just the pathogen, but also what the susceptibility testing may look like. So not just a name for the bacteria, but actually which antibiotic for that specific bacteria is going to be best to treat the given patient with. And we've had continuous monitoring blood culture systems in our laboratories really since the 1990s, which was quite a revolutionary step in the way we process blood cultures. But unfortunately, blood cultures are slightly problematic in that they're quite a slow test. They can take many days to get a positive result, possibly longer, and they're not as sensitive for particularly fastidious organisms. And for those of you that don't work in a laboratory, I'll just quickly outline what happens to those blood cultures as a general rule. So we have the patient, they'll have their blood test, have the blood drawn into the blood culture bottles that are then hopefully very promptly transported into the laboratory, where they make their way into a blood culture analyzer, such as the one you can see here. Each bottle is placed onto the analyzer ideally as soon as possible, and once the machine detects a positive detection, then it will alarm to tell the laboratory personnel to withdraw that blood culture from the machine in order to facilitate further processing. And so the blood culture bottles, they're basically vials which contain a chemical sensor at the base of the bottle, which can detect increases in carbon dioxide. And the living microorganisms, as they respire, do produce carbon dioxide, and they produce a colour change in the bottom of the bottles. And the blood culture machines, in fact, have a sensor which is monitoring those bottles every 10 minutes, and they're really looking for a change in that colour, and that change in colour or fluorescence in the base of the bottom of the bottle is proportional to the amount of carbon dioxide present. So a positive reading indicates a presumptive positive, i.e. the presence of growing and respiring bacteria or other microorganisms in that bottle. And the bottles also contain some resins which do aim to inactivate any antimicrobials which may have also been in the blood inoculated into the bottles. But those resins, unfortunately, whilst they do help pathogen recovery, they can't replace taking those blood cultures ideally before any antibiotics are given. So most blood cultures flag positive within the first 12 to 24 hours of being incubating on the blood culture analyzer. And so at that point, the machine alarms, a laboratory technician or scientist will come along, withdraw the bottle off the machine and put a couple of drops onto a slide, a glass slide for microscopy. And we'll also inoculate some agar plates with that blood culture broth for incubation in the incubators. So the gram stain is what we use as that first initial step. So the drops of blood culture broth placed on the glass slide, fixed and stained with what we call a gram stain, and then looked under the microscope to see if we can tell what this organism might might be. So the gram stain is actually a very old technique. It's been around for well over 100 years, but it's still very useful as an initial step to try and categorize what we think the causative pathogen might be in this blood culture sample. So on the left hand of the screen at the bottom, you can see gram-positive cocci. These are purple, they are round, and they are arranged in clusters, the classic sort of bunches of grapes. So these are staphylococci. And on the right-hand bottom of the screen, you can see gram-negative bacilli or gram-negative rods. So these are long, thin organisms that are staining pink. And within those groups, Staphylococcus, we can't tell you at that point whether it's a Staphylococcus aureus or some other Staphylococcus species just by the gram stain alone. And similarly with the gram-negative rods, we can't tell you which specific species at this point on the gram stain alone. But in most parts of the world, E. coli is the by far and away the commonest gram-negative rod to cause bloodstream infections. So the laboratory staff member will usually phone that gram stain result as soon as it's available to the treating clinicians in order to alert them to the fact that an organism has been detected in the blood culture and to make sure that the patient is reviewed and ensure that they're on an appropriate antibiotic to treat that bloodstream infection. And this is what the initial gram stain might look like in a laboratory information system such as my own in my laboratory. And here you can see it's a blood culture, the date that it's received, and that we've identified gram-negative bacilli in both the aerobic and the anaerobic bottle. So what we need to do next, because the gram stain, whilst it's useful, quick test doesn't give us all the answers, we then incubate agar plates for a further 24 hours to see if we can get those bacteria or other microorganisms to grow on the agar plates so that we can do further tests to decide what they are and what antibiotics may be best to use. And so agar plates is a mass spec type technology, the MALDI-TOF, which has also really revolutionized clinical microbiology in the last decade or so, which gives us a really accurate and timely identification down to species level. And once we know what the species is, then that's added to the report. But still, we haven't stopped there. We've got to do susceptibility testing to see, well, we've got an E. coli, it's a gram-negative bacillus, but now what antibiotics are we really needing to use to treat this organism? And there are various ways that we will perform susceptibility testing. Here on the left, you can see classic, what we call disc diffusion, where we have a lawn of the organism on an agar plate, and we put on various just filter paper discs that are impregnated with antibiotics. And what we're looking for is a zone around the antibiotic disc to tell us whether or not that particular bacteria is susceptible to that particular antibiotic. And there are other ways we can do that as well, either more with more detail with our gradient strips here, and there is also automated technology available that's frequently used to more accurately determine what the minimum inhibitory concentration of a particular organism might be. And so how we decide whether or not an organism is susceptible or resistant to a particular antibiotic is determined based on strict criteria. In my own laboratories, we follow the EUCAS, which is a European committee which standardized susceptibility testing. And also, just to note that the reports that we issue in our laboratories determining whether an organism may be susceptible or resistant to a particular antibiotic is also predetermined by a set of dosages that we are expecting to be used by the clinicians. And if the incorrect dosage is being used, then the susceptible result may in fact not be accurate. And also just to point out that in our laboratory, we may well test a number of different antibiotics against which the bacteria may or may not be susceptible. But in fact, we don't necessarily report all of those because we really try to guide the clinician to the most appropriate antibiotic to be using in that particular scenario. And so in my laboratories, at least, we do try to restrict what we report as an extra tool to guide appropriate therapy by the clinician. So in terms of blood culture positivity, what we see is that the majority of blood cultures actually flag positive within the first day of incubation. So maybe up to 75% blood cultures will flag positive day 1, a further 20% at day 2, and then you may see a few more coming positive days 3, 4, and 5. Most laboratories these days would not proceed incubating longer than 5 days, because it's been shown repeatedly that the vast majority of organisms will be detectable with our modern blood culture analyzers by day 5. Now, this slide I really just put up to remind me to tell you that the blood culture process is a very complicated one. There's a number of steps within that point, from where the blood is collected from the patient to the point where we may issue that result in the laboratory. There's a number of steps within that timeline where quality issues can crop up. And so what we're really going to be focusing on for this talk from now on is these issues from the time that before the culture is collected to the point at which it reaches the laboratory. We're not going to focus so much on those processes which occur in the laboratory itself, because what we know about blood cultures is that those pre-analytical steps are really key to making sure that our blood cultures are the best quality that we can possibly achieve. So how do we optimize blood cultures? Well, it's really about getting those basics right. We know that we can improve sepsis outcomes by getting those basics right. And just to put it in a very simplistic way, we want to be performing those blood cultures on the patients in the right way. So that really boils down to how we're taking those blood cultures. We want to make sure that we're performing them on the right patients. So that boils down to patient selection. We don't want to really be sampling patients that have a really low pretest probability or a very low likelihood of having a bloodstream infection. And we want to be performing them at the right time. And for blood cultures, ideally, that is really prior to antibiotics. Now, we accept that, patients may present critically unwell, in which case we obviously need to get antibiotics into certain patients as quick as possible, but we also need to be aiming to achieve blood cultures at the same time wherever possible. And we also want to be making sure that the blood cultures are being performed for the right reasons. So, and these are the kind of core principles that really underline not just diagnostic stewardship for blood cultures, but really on any pathology test. So in microbiology, it's really quite important to think about a number of key important principles. And this isn't just related to blood cultures per se, but in fact, any microbiological test. Because microbiology in most laboratories is still a very manual laboratory science, where you have a scientist or a technician actually looking at each plate for each sample and having to do some interpretation to decide, is this organism significant? Does this organism need further workup? Or is it actually just going to be part of the colonizing flora? And so with microbiology tests, it's really important to know the clinical question that needs to be answered, and then to take the best type and the best specimen possible to answer that clinical question. And so that's, again, due to the quality of the sample, the timing of the sample, and in fact, which sample you're going to take. And it's also really important to communicate with the laboratory. So for our laboratories, we really do request that the clinical details are always included with every microbiological test. And of course, if needed, there's always a friendly microbiologist to discuss any requests or results directly. And the reason that's so important for microbiology is, as we know, we have, our bodies are coated in a microbiome, so we have normal colonizing flora. And importantly, a lot of those organisms that can be part of the normal flora can, in certain circumstances, become a pathogen. And so that's where we need to have good clinical details to be able to interpret, well, in this setting, does this organism mean it's a pathogen, or is it actually just part of the normal flora? And so that's really the concept of garbage in, garbage out. So if you give us a rubbish sample, we'll probably give you a slightly rubbish result. And the result of any laboratory test is really only as good as the sample that's received into the laboratory. And so if we think about the diagnostic cycle, we as laboratory people break that down into the pre-analytical steps. So these are the steps that take place before the laboratory before the sample reaches the laboratory. There's the analytical stage, which is what we do in the laboratory, and those are really very tightly controlled. We have a lot of quality control within our laboratories to make sure that the work that we do is indeed controlled and performing well. And then there's the post-analytical steps, which is how we report that result that we've determined out to the clinician, and how the clinician interprets that result and what actions they take based on that result. And so it's those pre-analytical steps before that sample reaches the laboratory which are prone to the most errors within the diagnostic cycle. And this is what we're going to focus on, particularly with respect to blood cultures. So, and the reason we want to focus on those pre-analytical steps for blood cultures is that we know those are the key steps that can really optimize the quality of those blood cultures. And in particular, we will talk about the volume of fill, the number of sets, because those two components together make up the blood sample volume, which we'll talk about in some detail, the contamination rates, and that really relates to how is that blood culture collected, the positivity rates, so that really relates to not only the appropriate sampling, but also correct patient selection. Now, turnaround time, the transport to the laboratory, I won't focus on it in particular, just to suffice to say that really that should ideally be as short as possible. So these are the key quality indicators that we look for when thinking about blood cultures. So the volume of fill, so the amount of blood per bottle, we know for adult patients should be in the range of 8 to 10 mils per bottle. And the reason that's important is that the single most important factor when trying to optimize the sensitivity of blood cultures, that is how likely we are to actually detect the pathogen that's in there, really relates to the volume of blood. And that makes sense because there's a low concentration of organisms in the blood per mil. So the more mils you get, the higher the likelihood of detecting that pathogen. And really, we would like to see 80% of blood cultures, each bottle in that range for an adult patient, 8 to 10 mils. And along those same lines, the rate of solitary blood cultures, so a single bottle or a single set, again, does impact on sensitivity, because if you have one set, you've got half the volume of blood than if you have two sets. So again, we want to be aiming for less than 10% ideally of blood culture draws as having a single set. When it comes to contamination, we know that for blood cultures, contamination is a major issue, which we'll talk about in a bit more detail shortly. And that does impact on the blood culture specificity. So if we have got an organism growing in a blood culture that doesn't seem likely to be a true pathogen, then that can impact on patient treatment, management, length of stay. And what we want to do is really try and reduce that contamination to less than 3%. And in an ideal world, we should really be seeing that at less than 1%. It is achievable, particularly with some new sampling techniques and new devices out there that are recently out there on the market. The positivity rate, or what does that tell us? This is the proportion of blood cultures that have detected a pathogen. So really, we'd like to see that 8 to 15% or 5 to 15% in some guidelines, because that really indicates whether or not the right patients are being sampled, and also whether the right technique is occurring in terms of the volume of fill, number of blood culture sets, and also reducing the contamination. Because a contaminated blood culture may actually, in fact, mean that the contaminant outcompetes for the nutrients within the blood culture for the true pathogen. And just to mention, two other important considerations are time to loading. So the shorter the time as possible means a shortened turnaround time for that positive result, and also a shorter time to reporting to the clinician to make sure that the patient is treated appropriately. So as I've already alluded to, the blood sample volume is really that key component to optimize the sensitivity of the test. And it does directly increase the likelihood that an organism will be recovered, but it also importantly does reduce that time to detection as well. And we've known really since the 1970s that there is a very low concentration of circulating microorganisms in a bloodstream infection. And so that blood culture volume has repeatedly been shown to be the most important factor affecting blood culture sensitivity. And we know that actually for every extra mil you may be able to obtain from your patient, it can increase the positivity rate by 2 to 4%. And understanding that the blood volume is a function of both the individual fill volume of each bottle as well as the number of bottles does help. And as I've already said, laboratory standards and guidelines recommend 2 to 4 sets with 8 to 10 mils per bottle. And we should, in the laboratory or in the hospitals, really be aiming to monitor whether or not we are in fact achieving those standards by not just looking at the number of sets per patient which are being received, but also the individual volume of fill within those bottles, because monitoring of compliance is really important. And by monitoring and feeding back how those blood cultures are being performed is the first step in actually identifying where those standards may be not being met, and actually the first step towards improving. And we do also know that culture negative results correlate not only with a more severe sepsis, but also higher mortality rates. So when it comes to the number of blood culture sets, what we tend to aim to achieve is 2 sets. So that's 4 bottles, 2 aerobic and 2 anaerobic per patient prior to starting any antibiotics, with 8 to 10 mils of blood in each bottle. And if you are achieving that with your patients, then your test sensitivity is probably in the region of 90%. So what does that mean? It means that 9 times out of 10 cases of sepsis, you will actually manage to identify the pathogen that's causing the sepsis. If you only ever took 1 set, then you're probably maybe 20% lower chance of identifying the pathogen, around 70%. And of course, if you're only taking 1 set and not achieving a fill volume of 10 mil per bottle, it will be even lower than that. 3 sets would increase your sensitivity further, but probably 2 sets is the best balance between sensitivity and specificity in this respect. And, you know, there's numerous studies which are not new. They've been around at least sort of 20 years, really demonstrating that that volume is critical in terms of increasing your chances of identifying the pathogen. And this is just one example of a lot of literature out there that supports. Now, of course, the blood culture volumes that I've been talking about actually relates just to adults. What about children? What should we be doing? How much blood should we be obtaining from children? And now, unfortunately, there's much less consensus around this, and it depends on which guidelines you look to, and a lot of the guidelines do not say the same thing, except for the fact that guidelines do generally agree that the volume of blood sampled for children with sepsis should be proportional to the child's blood volume and weight. But what does that mean in practical terms? I'll give you a quick rule of thumb in a second, but just to highlight that the sensitivity issues matter probably more for children, because if we struggle to get adequate volumes from adults, we struggle even more to get adequate volumes from children. And so those positivity rates for pediatric blood cultures are generally much lower than for adults. And that's really related to the fact that we just don't simply get good enough volumes. I think rather than going through each of the different guidelines, I think what's useful rule of thumb, and the one that I usually use, is thinking about, for a child over the age of 1 year, as a rule of thumb, we're looking at the number of mils is the same as the age in years. But also noting that for very small babies, you're really not wanting to exceed 4% of blood volume, which is probably most important for very small babies. After a child is really over the age of 12, then they should be being blood cultured in the same way as for an adult. So then you're looking at, you know, really 2 to 4 sets with 2 to 4 bottles with 8 to 10 mils in each bottle, ideally. And pediatric bottles usually suffice for most, but noting that they accept lower volumes. So if you're looking at, 3 mils for a 3-year-old, that's 1 bottle. But if you're looking at 6 mils for a 6-year-old, then you're looking at 2 pediatric bottles. And so the reason that's important is that if we continue to just, undersample children, then we're really not going to have an impact on improving the sensitivity in pediatric blood cultures in the way that we need to. And also remembering that a lot of the organisms that cause sepsis in children are particularly fastidious organisms that may not grow as abundantly as organisms such as Staph aureus or E. coli. So organisms such as Haemophilus influenzae, Streptococcus pneumoniae, Neisseria meningitidis, these are more fastidious bugs that are a bit trickier to grow. So moving on to contamination. Now we've sort of set the benchmark where we want to really be aiming for a contamination rate of less than 3%. In fact, the United States have a specific requirement for laboratories to track their contamination rates and need to demonstrate that their rates are less than 3%. Whereas in Australasia, we don't have such a benchmarking program either available or a requirement. But I would argue that actually regularly measuring our contamination rates, it should be part of our standard best practice towards blood cultures. And setting a target contamination rate, measuring what it is, and continuing to measure it is a really key step to improve. And the problem that we have in the laboratory is obviously that contamination rate really does also relate to how that blood culture is being taken and performed. And if we're in settings where most of the blood cultures are being taken by clinical staff, then we don't have a direct control over that practice out there in the coalface of the clinical emergency departments. And so why is contamination such an issue? Well, we know that contamination is unfortunately very common. And it leads to a number of problems, which includes patients being given antibiotics unnecessarily. So the contaminated blood culture may become positive, but it may be another day or two before we've actually been able to identify, well, what is the organism in there, and actually make an assessment that it's probably more likely to be a contaminant than a pathogen. But meanwhile, that patient has remained on antibiotics maybe for a day or two longer than they actually needed, whilst waiting for that final result. It can also lead to unnecessary diagnostic work, such as further imaging, as well as have a profound impact on costs. That may be due to either the patient staying in hospital for an extra day or two, or because of the extra imaging or other interventions that they may have unnecessarily had done, when actually all along the blood culture was a contaminated result and a red herring. So to improve contamination rates, we need to make sure that we're following the best practice when it comes to blood culture collection technique. And so really what we're talking about here is a strict aseptic technique using standard precautions. We need to make sure we're sampling venous blood, not arterial blood, and washing hands, good hand hygiene, wearing gloves. The gloves themselves are not don't need to be sterile gloves as part of the aseptic technique, but obviously gloves do also protect the phlebotomist or the person performing the venipuncture from any venipuncture needle stick injury that may accidentally occur. Each bottle needs to have the rubber bung cleansed with 70% alcohol prior to any inoculation with the blood sample, and that's because those bungs themselves are not sterile. And what's really important is that the alcohol is allowed to dry, because it's that drying step that really kills any colonizing bacteria. But obviously the most key step is the venipuncture site preparation. So vigorously cleansing that venipuncture site, 70% alcohol for 30 seconds, which is actually quite a long time, but that's the most key component of the site preparation, and then standing back and allowing to dry for at least 60 seconds, because as I said, that drying step is really key. Don't go back and retouch the venipuncture site after the skin prep has occurred, because if you do, you will then have to go back and start the procedure all over again, because you will have contaminated your sterile field. Generally, indwelling catheters are not recommended for sampling because they do have a higher rate of contamination, unless, of course, the clinical question that you're trying to answer is whether the venous catheter is the source of the bloodstream infection, in which case a paired sample from both the venous catheter and the peripheral site is required. So wherever possible, we strongly encourage that a closed collection technique is used, as you can see in the picture, with a safety wing set. This does reduce the risk of needle stick injury, and it also encourages the correct volume, because what you can do is then mark off your 10 ml marker on the side of the bottle, stand the bottle upright, and wait for the blood flow to fill up to the point at which you've marked on the bottle. The bottle should be gently mixed by inverting the bottle to ensure that the blood is distributed evenly throughout the bottle and with the broth. Make sure that standard precautions are adhered to with safe disposal of any phlebotomy equipment, and obviously appropriately label the samples and get them to the lab quickly and get them into that incubator as soon as possible. If they can't get into the incubator quickly, never put those blood culture bottles in the fridge. They should stay at room temperature. So there have been studies out there to look at some little devices out there on the market to try and reduce contamination rates, which do seem to work quite well, such as this one, which is a little diversion technique whereby the first few mils of blood are actually not inoculated into the blood culture sample itself, but in fact are discarded, and they can have quite a good impact on a contamination rate and may be useful, particularly in settings where there does seem to be a very high contamination rate. The other thing that I get asked quite a lot about is whether or not those two sets need to be taken from two separate venipunctures, or whether in fact one single venipuncture could be sufficient to inoculate the two sets. And there is data out there which does suggest that the single venipuncture approach is just fine, because really if your aim is to increase that sensitivity and get those two sets and increase the blood volume overall, then often the barrier to getting those two sets is the need for a second venipuncture in a busy ED department where the clinicians may simply just never get to go back to that patient for a second venipuncture. So in my laboratory settings, we do advocate for a single venipuncture to get two sets, and that has really helped improve obtaining two sets. But we do ensure that those two sets are not taken from a cannula insertion, but is actually a dedicated venipuncture. Who needs blood cultures? Well, the patient selection is also key. Obviously, once you've decided which patient needs to have the blood cultures taken, an aseptic technique is important for the contamination, but the patient selection itself is really key to inform your positivity rates. And so what we try to ensure is that patients who have a suspicion for an infective endocarditis, for example, or a line-associated bloodstream infection, and particularly an intravascular infection, as well as patients with severe infection, sepsis, septic shock, definitely all need to have those blood cultures taken. Where blood cultures may be less likely to be helpful, maybe non-severe infections, so mild urinary tract infection or mild cellulitis, mild pneumonia, where often we don't typically see a bloodstream infection or a positive blood culture from those sorts of patients. And particularly patients who may have made it to the ward or have had recent surgery and are otherwise well, but have a post-operative fever or a single episode of fever, or a slight rise in their white cell count, and particularly patients where a viral infection is more likely to be the diagnosis, then we would discourage blood cultures in those patients. Because the problem is that then if you get a contaminant, it may negatively impact a patient who actually had a very low pre-test probability of having had a bloodstream infection in the first place. So microbiology, as I hope I have convinced you, plays an important role in improving sepsis outcomes. But one of the slight controversies, I would say, is, well, whose responsibility is it to be monitoring the quality of our blood cultures? is it the laboratory's responsibility, or is it in fact the clinical teams, given that most of those factors which we've talked through which affect blood culture quality are really at that pre-analytical level? Well, in fact, from the microbiology laboratory perspective, there are in fact several consensus guidelines out there which do recommend the laboratory should measure certain quality indicators to make sure that the blood cultures coming into the laboratory are of sufficient quality. And that really does also sit on our quality guidelines, which is really should be seen as part of the laboratory's role. And so the laboratory does have an important role to play alongside the clinical teams to ensure that these blood cultures are being performed in the correct way. So as one of my roles with the Royal College of Pathologists of Australasia quality assurance programs, I actually work with the microbiology team. And we actually were approached by NPAC in Australia to ask whether we could help with a survey to determine what laboratories across Australasia are actually doing in terms of measuring blood culture quality. And so in response, we undertook a survey and we invited over 200 laboratories that currently participate in the RCPA QAP bacteriology QA to answer an online questionnaire, which was quite a lengthy questionnaire. We really felt that we wanted to delve in fairly deep into blood culture practices within the laboratories within Australasia. And the questions included quite a wide range of not just pre-analytical, but analytical and post-analytical aspects of blood culture processing. And we were fortunate enough to get 91 respondents. But what the results really demonstrated was that laboratories in general had an excellent compliance with those analytical standards. So the bits that we do in the laboratory, we were doing really well. But there were lots of missed opportunities for aspects to do with the pre and the post-analytical steps. So of those 91 laboratories, only 3% of labs were actually monitoring volume of fill. 11% of labs were monitoring the number of blood culture bottles being received. Only in less than a third of laboratories were actually measuring contamination rate and ensuring that it was less than 3%. And only 20% of labs had any idea what the positivity rate. So there's a huge opportunity here to improve what we're doing. But as I say, one of the main barriers may be that laboratories may not consider it their primary role to be doing this. And it is quite difficult. It requires a lot of ongoing education, continuous audit and feedback, which actually takes time to do and takes time to do well. So in New Zealand, we actually undertook a national audit of blood culture standards across various different regions for those blood culture quality standards. And there was really quite a variation in what we saw. I'm pleased to say that my own district here at the bottom of the table wasn't doing too badly compared to others. Our contamination rate, thankfully, was less than 3%, positivity rate within the range, and the mean fill volumes over 8 mils. But look here, our solitary blood culture rate was in the region of 50%. And even in some other regions, for instance, the mid-central region, we're seeing contamination rates of over 6%. So unless you're actually monitoring and looking at what the performance is, you actually have got no idea really how well your labs and your clinical teams are performing in that respect. So really the conclusions from our national audit was that contaminant rates, as I say, a significant variability with significant room for improvement. Notably, the feedback is that it's actually quite time consuming and often relies on manual auditing to get this data. And over time, I think as blood cultures, manufacturers and I guess the companies that provide us with the blood culture machines will also be improving on what we can have in terms of data analytics to make the auditing and the blood culture quality assurance improve in that respect. So just almost coming to the end, just couple more slides just to also highlight another audit that we ran in our intensive care unit in Wellington Hospital, which, sorry, that's the wrong slide. I'll just move on. Yeah, to this slide, sorry. We looked at the Wellington ICU blood culture contamination rates, because we did feel that we were seeing quite a lot of contaminants. And here you can see we were right, contamination rate of 8%, which with just a bit of education in terms of how they were sampling from, particularly from indwelling venous catheters, we managed to halve that rate, but it was still sitting at over 4%. And this was really just by educating mainly the nursing teams on how to decontaminate the hubs for these venous catheters prior to sampling. Still more work to do because 4% is still much higher than it should be. But really, I just included that to highlight that you can make a difference. I'll just skip to my last slide. Thank you so much for listening. I guess the main take-home messages with regards to blood cultures is that, you know, we have to remember that blood cultures are really all we've got at this point in terms of the gold standard investigation for sepsis. It's probably going to be this way for at least, you know, the next wee while yet. And we really have to make a good attempt to optimize patient outcomes from sepsis by getting those basics right, reducing contamination, increasing the number of sets, increasing that full volume, and making sure that we are sampling the right patients. And so I just would like to say a big thank you for listening. Here's the team in one of my laboratories, and would like to invite, if we have time, any questions.
Thank you so much, Dr. Elvie, for that very detailed presentation. So I would like now to open the floor to any questions you may have about the topic presented today. To ask a question, please type it into the chat box located at the left lower corner, and we will read it out to our speaker. So actually, we did have a few questions sent out during the presentation. So I think the first question is that, you know, we've observed a lot, especially in the ER, about a high proportion of blood culture that consists of only one set. Do you observe that, you know, in your institution or somewhere that you think that, you know, it's a very common practices, and how can we actually improve that?
Yeah, so I actually presented my data on one of the slides, which showed you that 50% of our blood cultures when we audited were single sets. So the main improvement around that was to educate, to say actually, to get those two sets, it's okay to take from a single venipuncture to get the 40 mils, just so long as that single venipuncture is performed really well with an aseptic technique, is not taken through a cannula insertion. And I haven't shown you this data, but we went back and re-audited this year and have demonstrated now that we're down to a 20% single set collection, which I think is a really good improvement without any increase in contamination. But also, interestingly, we increased our positivity rate by 2%. So I think that really demonstrates the value of A, getting sufficient sets, and B, accepting a single venipuncture if the main barrier is going back for that second venipuncture, which I think in the busy EDs is commonly the main barrier.
Yeah, and I think that's a lot. I think that's where a lot of, you know, a lot of sharings that we receive is that, you know, they do not want to prick the patient over and over again. So I think it's the awareness that, you know, would actually bring this kind of attention to the healthcare workers. And I think speaking about venipuncture itself, I think you mentioned about the close collection being the best practice, right, for blood culture to ensure the volume, to minimize the risk of needle stick injuries. However, we still see a lot of open collection, like syringe and needle collection with blood culture. How do we overcome that? Or is there any different in terms of the technique or practices that they need to take note of?
Yeah, again, I think it boils down to education and training, because a lot of that practice is kind of cultural within a particular unit. That might just be what's done and what's always been done, with an underappreciation of the risks, you know, potentially with using that needle and syringe method, possibly not even changing the needle between taking and inoculating. So it's really not the recommended practice. And I think it all boils down to education and training. So the more you can get into your ED departments to educate and train the correct technique, then I think, you know, you would reap the benefits from that.
Right. So we have a question regarding pediatric collection. Interestingly, it was mentioned that, you know, for patient that is adult that has difficult veins and they are unable to collect maybe 2 bottles, are they able to use single bottle from a pediatric vial itself?
Yes, and that's, so you're talking about an adult patient with a low volume.
Correct.
Are we? Yeah, that's fine.
Yep.
That's fine. If you've got a low volume, then we would normally suggest either you could use a pediatric bottle or the aerobic bottle of a set.
Okay.
Rather than splitting low volumes into each.
Right. Yeah, I think that was my next question to you. You know, is it better to collect from a one vial or is it better to actually split? Right.
I would say if you've got a very low volume, then the pediatric bottle would be useful.
Okay. In terms of the collection itself, right? I think it was mentioned about, you know, venous sample would be the most appropriate samples to be collected. But why is it that, you know, in terms of best practice, we are supposed to collect venous sample as compared to arterial blood? Would there be any deviation in results?
Yeah, so there is data actually to suggest that yield is higher from venous blood, obviously from a safety perspective as well. And also what we have also found in our audits, particularly of the ICU, where there's been a tendency to sample from arterial lines, those arterial lines as well do seem to have a much higher contamination rate, which you can actually see on one of my slides. I didn't specifically mention that, but we certainly saw that the highest rate of contamination in our ICU at least seemed to be coming from the arterial line. So we would really recommend against arterial sampling.
All right. I think, Dr. Julia, this is a personal question from me as well. I think in terms of cleansing the site, or what if those patients have allergic to alcohol? What would be the alternative cleansing option for them?
So chlorhexidine solutions or povidone, iodine, either of those, anything which is going to adequately kill the colonizing flora on the skin. But key is to make sure that it's vigorously swiped for long enough, so 30 seconds, and then importantly left to dry, because I think often it's the drying step that is missed, and that can lead to contamination because the killing occurs during drying as well.
Right. Yeah, I think that is a very interesting thing. I mean, this is something new for me as well. I think it's, I didn't know that we are supposed to wait for the alcohol to really dry up, to actually, because most of the time I thought that, we are supposed to wait for it to dry because it will cause less pain for the patient, when we are inserting the needle, not so much as to killing the flora itself.
That may also be true, but for me, I'm more interested in the bacterial killing. Yeah.
Yeah. So maybe we can take one more question regarding gram staining. So they were asking whether they are allowed to do gram staining for blood together with blood culture itself. So I'm assuming, on top of blood culture, are they able to do it together for the other test itself, a venous sample itself?
You mean directly off a blood sample that hasn't been cultured?
Correct.
No, because the concentration of organisms is so low that the gram stain off just the blood is way too low. You just wouldn't manage to see anything. You need the incubation step to get the bacteria multiplying enough that you can actually see them under the microscope. We do occasionally get phoned by our hematology colleagues where they may have seen bacteria on a blood film, for example, but that's usually in very severe sepsis cases. And what tends to happen is then the next day their blood culture flags positive on our machine. But no, the issue with gram stain direct on a blood sample is it's a low concentration of organisms, which would be much too low sensitivity-wise. There's a lot of work going on looking at molecular techniques of blood without needing to wait for blood culture incubation steps. There's a lot of interest and a lot of work going on in that space. But at the moment, none of that technology is ready. And again, it boils down to the sensitivity, because you've got such a low number of organisms per mil. The sensitivity of those techniques is not yet good enough.
Understood. All right. Unfortunately, due to the time constraint, we will need to conclude the webinar. So rest assured that any questions you have will be addressed via an FAQ that will be emailed within 2 weeks. Please do take a moment to ensure you complete the feedback on this session upon exiting this webinar. So thank you so much, Dr. Juliet, for addressing all the questions and for the very detailed presentation. So we hope you enjoyed this presentation and look forward to seeing you at the next webinar on the 8th of November.